Go.
Hi, my name is Tracy Klein, and I'm an occupational therapist here at Mott.
And I'm the patient.
And we're going to start off with doing upper extremity range of motion. So if you want to lay that down. So usually it's best to start either at the shoulder or at the hand and work your way either down the arm or back up towards the arm. But we're going to start with the shoulder. So I'm going to support by her wrist, and then I'm going to put one hand up on her humerus, and all of my pressure is coming from the hand on her humerus. You don't want to cross over any joints when you're doing range of motion. You're going to first reach up straight towards the back wall and make sure the thumb is leading the way. You're going to go all the way up into the patient's comfort level. So if they're going to say, oh, this is painful, you're going to stop wherever they say that it's painful at. And you want to hold each stretch for about 15 to 30 seconds and then come back down. So that first one we did is called shoulder flexion. We're going straight back towards the back wall. The next one you're going to do is abduction, and you're going to come out like a jumping jack. So the arm comes out to the side, up towards the ear. And you should be able to reach all the way up towards the ear for full range. Come back down. And for both of those, like I said, the thumb is leading the way. The other shoulder movements that we like to do is internal and external rotation. So you bring the arm to a nice 90-degree angle, and then you're going to bring the hand back, like she's kind of punching the back wall or punching her pillow. And then you internally rotate, bringing it back down. So when you internally rotate, our arms do not go as far as they do for external rotation. So please do not force your patients to bring their hand all the way back down towards the bed.
Thank you.
Yes. The next one to do is after the shoulder is our elbow. And the only motion our elbows do is flexion and extension. So you're going to take palm of your hand towards your shoulder. And most patients should be able to touch their shoulder. You're just going to hold there at that end range. And then bring that arm all the way back out. Sometimes this one's difficult because patients have PICCs or IVs in their elbows, so you just do it to the patient's comfort level. So after the elbow, you're going to do your forearm, and you're going to do supination and pronation. So you're going to do palm up towards the ceiling, and palm down towards the floor. And then after forearm, we go to the wrist, and you're going to do wrist up towards the ceiling, and wrist down towards the floor. And then fingers are next, so we make a complete fist, and then you open your fingers all the way up. And most patients are able to help you with all those movements, and if the patient can help you complete any of the range of motion, so they're helping to lift their arm up, that's great, versus you just doing all the action for them. Nice job.
Thank you.
I'm Chris Tapley from physical therapy, so I'm going to go over lower extremity range of motion now. And like Tracy said, if the patient can help you, we definitely want them to. We can also start this though early on when the patients are still intubated, sedated. We really want to be maintaining that range of motion as best we can at that point as well. So it can be done throughout the whole spectrum and should be done. Generally consider this part of your normal daily care of you're getting them cleaned up, you're getting them dressed, go through that range of motion at least once, preferably twice a day. Going through each of the motions throughout the whole body. So we're going to start, same thing, we're going to start at the hip, and for the hip what we're going to do is just bring it all the way up and bring it back down. Is important. Colleen's got pants on, so it helps, but with our patients we do want to protect their decency, especially with our adults. So keep that sheet between their legs, something like that, just to protect them a little bit. And we're just going to bring that hip all the way up. Again, we're going to take it to patient comfort and bring it up just to that flexion and then all the way to extension. The other motion that we want to do with the hip here is we also want to do a little bit of rotation. So same thing with the shoulder, but in this case we're going to bring the hip up to about 90 degrees and we're going to rotate the foot towards the middle of the body and then we're going to rotate the foot out. Again, here we go into the middle a lot easier for most people than going out. So don't force it, we're taking it just to patient comfort. Or if they're not able to talk to you, just take it till you feel slight resistance. You're not looking to force a motion right now. Bring it in and then back out. So that's the hip. If the patient is able to get onto their side, and we're going to roll over here in a little bit and I'll show you one other motion. We can also do hip extension, but that doesn't, not all patients are able to do that, or we don't do that every time. So, but I'll show you that next. The other motion we want to do is at the knee. So our knee does flexion and extension, but one of the big motions we want to do is we want to bring it up to that 90-degree position again, and we're going to straighten that leg straight up. What that's going to do is that's going to stretch that hamstring.
Oh, that feels good.
Yeah. The reality is for a lot of our adult patients especially, they're going to be tight here. So we want to take it to their patient, to their comfort level of, you know, not cranking on this. And Colleen's got pretty good range of motion. You may not be able to get this on most patients, but just bringing it up, just to that comfort level. And then the next motion that we're going to go to is we're going to go to the ankle. And this is probably one of the most important motions that we can do. Just because our natural resting position is with those feet flat. Using our Renard boots, using our basic positioning is great, and we want to keep that up, but we also want to supplement it a little bit with some additional. Renard boots do a nice job of keeping the foot in about a neutral position, maybe a little less. Most people, and for walking, we need about 10 degrees beyond that neutral position. So with this, for this motion, what we're going to do is we're going to take, cup with our hands right around their heel, right around that calcaneus. I like to use my forearm just so I don't have to do quite as much work. And then I just use my body weight and I just roll into it with stretch. What we want to avoid doing is just coming and grabbing the top of the foot and pulling in, because what it does is it rotates that foot out. It'll stretch the mid portion of the foot and not actually stretch that heel at all, or stretch that gastroc at all. So we're going to come in and then just pull it straight up like that. Again, like Tracy had said, holding it for about 20 or 30 seconds and then coming back down. We don't need to worry as much going into dorsiflexion, or I'm sorry, into plantar flexion here. But what we do want to look at also is a little bit of rotation. So bringing the foot all the way to the middle, it's called inversion, and bringing it all the way out for eversion. And again, just a gentle motion here, about 20 to 30 seconds on each of those positions. And then that last motion, and I apologize, I forgot one for the hip. What we're going to do is we're going to do abduction, adduction. So we want to just slide that foot out to the side, and we'll slide it back to the middle. Okay. And again, if the patient can help with this one's a huge one for them to help with, because this is the motion they're going to use for getting out of bed later on. To slide those feet over to the side. All right. So that's that. And again, once a shift, we can do this. At a minimum once a day. Should be at least twice a day. Once in the morning, once in the evening before they go to bed for the night. Just a nice stretch. Families can help with this. Nurses can help with this. If therapy is involved, we will help, but it's not a skilled therapy for us necessarily come in and just do the range of motion. So we need everybody else's help with it as well. So,
can I ask a question?
Yes, you can.
So some of our adults are extubated that day or within 24 hours. Yep. Do you think it's useful to do range of motion on those adults as well? Or should this just be for someone who's extubated and or planning on, we anticipate them being in bed longer?
I would say it's beneficial to do it on all of those patients and to teach the families how to do it, especially for the upper extremity range of motion, I would say, and I can defer to Tracy a little bit more on that. But with the sternal incisions, with that motion, we need them to get those arms moving, and they're going to be hesitant to do that.
And it's going to be painful too, but the more that they move and the more that family encourages them to move, the better it will be for the patient.
Okay, thank you.
So we're going to go into showing you guys how to roll a patient, get them sitting up. Everybody does a really pretty good job with this, but we're going to try to give a few tips that may make everybody's world a little bit easier, both in your role as a nursing, but also for the patient. What we're looking for when we start to mobilize these adult patients is we want them to do as much of the activity as they possibly can. We're working towards independence and getting them up and around. So I'm going to come around to the other side and trade spaces here with Tracy. And what we're going to do is we're going to roll over to the side. So Colleen, what I'm going to have you do first is I'm going to actually have you bend this knee right up. And we're going to use a log roll technique to come right over to Colleen's side. This is great for changes in bed. If you're needing to do a whole bed change, if you need to change a brief, anything like that, you can use just this technique for rolling to the side. Also use it for positioning. You guys all do a great job with positioning, but this is a great way to get them fully up on their side, to be able to get the wedges, get the pillows up underneath them as well. So Colleen, like I said, why don't you bring that leg up? And then
Do you want the bed flatter?
Yeah, let's go ahead and put it down.
So the easiest way to roll is to have the bed as flat as possible versus having the patient have the bed elevated. The
end at the highest height, so you don't hurt your
Yes.
back.
Yeah, that would be the other side, so, yeah, put it at a comfortable height for you. The thing to be aware of is if you have two different care providers, making sure that it's at a height that's comfortable for both people. If you have one that's significantly taller than the other, you're gonna have to find a compromised position between the two. The other thing to remember is we're just working rolling now, but then we're gonna go into sitting up. We need to be a little bit careful with the height of the bed when we start sitting a patient up, because it's fairly uncomfortable to sit up and have your feet just dangle in midair. So you kind of have to find that happy compromise there too, and judge your patient on whether or not they can sit while we lower the bed. So Colleen, what I'm gonna have you do is I'm gonna actually have you reach across, grab my arm, and I'm gonna come here. I can come if Colleen's able to help me, I can hold here and have her help. We can also bring that rail up and have her pull there if I need an additional set or need additional help. What we want to work towards is that independence as much as we can, so they're not going to have that railing at home. Your other option is to have them come to the edge of the bed, to the mattress, and come across that way. So let's go there, and then that way it frees my hand. I'm going to come right behind your shoulder blade and right at her hip, and Colleen, I'm going to have you roll right over to your side. Perfect. So make sure that she's all covered up.
Thank you.
You're welcome. Now go ahead and roll out your back. This time I'd like you not to help us at all.
Okay.
Because the reality is there are going to be plenty of times that that's the case. You're still going to want to bring that leg up into a flex position if you can.
Bring that arm across the body.
And then this is where two people can come in and we can kind of do that roll. You don't know how to roll.
I know. So that was easy.
So, but then you're going to bring it into that position. Nice thing is then from this position we can go right into sitting up. And by far, for our patients with a sternal incision, this is the easiest way to sit up, is from this log roll. It seems counterintuitive that they're rolling to their side is going to be a more comfortable position, but by far it is, rather than trying to sit straight up where it's putting full force and full pull across that sternal incision. So from this position, what we're going to do is, Colleen, I'm going to have you slide your legs over this side.
Did my butt show?
Nope, your butt's covered.
Because I do this one just
Yep.
for one person, and I'll help you at
Yep,
this one.
sounds good. And so we'll come here. I'm going to put my hand on the hip. Colleen, I want you to push with this hand. And then as you come up, you're going to push with this elbow. And we're going to come right up to a center.
So she was pushing with her,
She was pushing with her right arm, yep. With both arms, actually. So the upper arm, what they're going to do is they're going to use that to push against the mattress. As they come up a little bit, then they're going to use that elbow to help push them up as well. What we don't want to do is we don't want to take them from that position. Go ahead and lay back down for me, Colleen. We don't want to take them from that position and have them pull here and do any sort of just pulling across like that. That's going to put a lot of stress across their sternal incision. One, going to be very uncomfortable. Two, it's going to actually break your sternal percussions. Pushing down into that is okay. Pulling across is going to create a distractive force across that sternum, which is what we want to avoid.
so they should push down into the mattress.
Into the mattress, yep. Yep, you got it. So this time I'm going to have Tracy help me, and Colleen, I don't want you to do it as much. You can help a little bit. For more dependent supine set transfer.
So actually, I'm kind of into the bed, so I'm closer to Callie. Sorry.
So, and we're going to come in. My hands are going to come right underneath Colleen's shoulder and kind of cup at that head and neck there.
I can also guard the head with one of my hands and help with the other shoulder.
And we're going to bring those legs off, and again, I'm going to come up to hips and come on up. So it's a very similar motion. This is a great if you've got a person who is a little bit more deconditioned, may need a little bit more help with sitting. It's good to have that second person there to help do that. You don't know for sure how people are going to do. If you're in doubt at all, have a second person there, have a third person there. A word of caution, what can happen is you can get too many people in the room. I would rather you have that help, but if you start throwing 4 and 5 people around a patient every time they have to move, they start to think that they have to have 4 or 5 people every time they move. So we want to do it with a safe number of people, but we also want to be realistic that, hey, they need to do some of it themselves. So.
Sometimes it's just beneficial to have another nurse in the room just for line management.
Yeah.
You know, just to make sure the lines aren't getting tangled and.
Yep.
I think the cupping of the shoulders is a good tip. I don't know that I've heard it put that way, so
Yeah.
I think that's great.
Yep. So the other thing that we're going to do is we're going to show you how to do a transfer over. We're going to use the commode, and then we'll also probably try to go to one of the bedside chairs, or I'll give you a couple tips on the bedside chairs. So once you're sitting on the side here, what you want to do is until you know that that patient is safe, you want to have somebody sitting with them, and then Tracy will go ahead and lower the bed down.
we're gonna get the bed as low to the floor so that their feet are touching as possible. Most of our adults will be tall enough that their feet will actually touch.
It's weird situation, not weird situations, but situations you're gonna run into. Our air beds do not go low enough even for most adults to touch the floor. Some of our ICU beds, more specialty beds, don't go low enough. So you wanna get them as low as you can. The air beds have a seat deflate option. Use that. Just know when you use that seat deflate. Yeah, we should go there.
Okay.
So yeah, let's scoot forward a little bit. There you go. When you use that seat deflate, just know, don't deflate that seat until you're ready to go. Because once you deflate that seat, they're essentially sitting on the metal frame of the bed. So you don't want them sitting there for 20 minutes while you get everything set up, because it's not going to be real comfortable. You saw Colleen kind of scoot yourself forward. What you're going to find is often you get the bed to a certain point, and then you're going to slide them forward, so you're not so low that you can't assist them. To assist Colleen over, first one we're going to do is I'm going to do by myself, and then I'll have Tracy help me on the second one. What we want to do is your big job for yourself is to protect your back, and along with protecting the patient. So you want to do what's called smothering your contact. So what I'm going to do is I'm going to get in as close as I can with Colleen. I'm going to have Colleen come here.
Should I grab it?
Yep, go ahead and bring your hands right up around my shoulder. I'm going to bring my hands onto Colleen's hips, and we're going to stand up, and we're going to turn and come across, and it goes, okay? Pretty nice, easy. Now, if you've got a fairly mobile person, they've been doing a great job, go ahead and come on over, Colleen. You can go as easy as here and just say, okay, Colleen, I'm going to have you go and grab onto my elbows, and I'm going to grab here. I'm going to have you lean forward, and we're going to stand, and then come across as well. Okay? But that first time that you do that transfer, I would rather you be in there a little bit. You need to explain to the families and to the patient, hey, this is why we're doing it, we just want to be safe with it. Especially with an adult. Kids are less weird about it. Adults, all of a sudden, you're in their personal space. You just need to let them know what's happening, and most of them are fine with it, and that you're wanting them to be safe. Obviously, you're going to have your line set up so that you're not tangling into those lines and everything like that. Coming back from the commode is going to be a very similar thing. What you want to do, though, again, is we're going to come in here, and I'm going to have you stand up. We're going to turn. When we sit, we want to sit as high in the bed as we can. So, because if we sit here at the end of the bed, you're going to be boosting them up in the bed once you sit down. So go ahead and sit down. Good. As Colleen sat, the other thing that I do is I give a little bit of pressure across her back, so she's kind of leaning back into me as we sit. And I come down with my knees together with her, and slowly let her come down to the bed so she'll jump.
Do you have any suggestions if the patient is soiled and you need to clean them or they need to clean themselves, how to have that happen?
From the commode,
Yes.
or
she's used the commode. She needs to be wiped.
Mhm.
What's the best way to do that? Do you have any suggestions?
The best way is to have another person come in, so you have the one person in front who's helping with the transfer, can help just have her stand and statically
hold.
stand while someone else is assisting with the hygiene area. And then if need be, take breaks. If she can't stand for very long, you know, have her sit back down on the commode chair, take a break, and then do it again until you can transfer back to the bed.
Is there any trick, if you have a patient that's somewhat unstable yet, not real strong in the leg, is there any trick that you support their knees or
Yep.
something to keep them in that position for a longer period?
So what I can do is, Colleen, this time and I know it's hard, but I want you not to help me at all, and we'll stand up. So what I'll have you do is go ahead and spread your knees apart like that. So I'm going to block my knees right at their legs here. And so what I'm going to do is I'm going to still come in here and get low. And as Colleen comes out, I'm going to block those knees so she can't come down. I've also kind of counterbalance behind here at her hips and come up. If you need to, when we're doing hygiene and it's a little harder, we're going to come down and get right on their rear end to kind of boost them up a little bit. But then you can hold here and kind of prop with those knees to help support.
So your knee is pretty much with her knee.
My knees are pretty much with her knees. And you do want to be careful, especially with our intake-regulated patients, things like that, that we're trying to make more bony contact versus my knees into their thighs or my knees into their shins, because that's going to be uncomfortable. You know, in a situation where they start to collapse, you get your knees in there and you kind of get your hips in and you just block them the best you can. But overall, we want to try to make more of that contact that way versus running the risk of bruising and things like that. Use your body. And the reality is you're going to block with those hips, those knees, kind of your whole leg to kind of help hold that person up if need be.
And in terms of you, the nurse or you, the person assisting
Mhm.
this individual, how do you protect your back while you're doing it?
First and foremost, it is smothering those contacts, so staying in close. If you're trying to work out here, you're gonna hurt yourself doing it. The other thing is using those knees, keeping your pelvis up underneath you so that you're not getting into that extension like this. Those are probably the other big things. The other side is if it's a bigger individual, get a second person. So you can do that same stand with a person on each side coming up. You can each be, so go ahead and come on over to the remote here.
To do it.
And here's where, scoot your bed out of the way. It's beautiful things that the beds roll. And we've got bigger rooms that we can get rid of them. So we can come in from each side and we can turn. Yep.
Thank you.
And we can block here and then we can help come up
Oh,
and come lower. Like
okay.
this.
Oh, yes.
And then that way,
That's useful.
both of us are there
For
to
sure.
block
Mm-hmm.
and can help. And then somebody else can still come in from behind to do hygiene or whatever needs to be done. Okay.
Thank you.
Close it down. And the other thing you want to do is you want to make it as safe and as comfortable for the patient as you can. If we have one transfer that goes really ugly or really badly, it creates a fear factor and it's much harder the next time we go into a transfer to try to do that. We kind of have to talk the patient down and figure out. So we want to make sure it's set up well. And if there's questions, if there's any hesitation, one, use your lift team. Your lift team is here, they're good. The thing with lift team is you are in charge of whatever transfer is going on. You know the patient better than they do. So if you know that there are specific things that need to happen with that patient, make sure that you mention it and stick to your guns on it. If they're saying, oh, no, we're just gonna do it this way, and you know that that's not the right way, tell them and don't let them do that transfer that way. We've had some incidences there where things have happened where the lift team has not listened to nursing. It's been addressed, they're doing a much better job about it. But just be aware, you are ultimately in charge of that transfer. And it's okay for you to tell them, no, we're not gonna do it that way. And the other side of it is, if you don't feel safe, don't do it. We wanna make sure that we provide a safe, easy transfer where the patient's not getting hurt, nursing isn't getting hurt. But we also wanna get those patients up and moving as quickly as we can. So we gotta find that happy medium between them.
Okay. And lift team is available?
Lift team's available 24/7.
Perfect.
And they are a little less available in the evenings and in the night shift. They are available, though there's only a couple of people to cover both main and lot, so you may wait a little bit longer. And the thing with lift team is you have to do a little bit of anticipation. If you know you want to get a patient up in 20 minutes, 30 minutes, call them then. Don't wait until you're ready to get them up, because they have to respond, they have to get here and get there, be able to do it, so.
Okay. All right.
Any other questions?
Colleen, can you think of anything else we should ask
I don't
our
think
experts
so.
here?
I just want to reiterate what Chris said, be as safe as you can with the transfer, use your resources, and I think Chris gave a lot of good tips on keeping our nurses and our techs safe and doing the transfers and keeping our patients safe.
Yeah. And the other side of it is if it's a difficult transfer, you're not sure, ask them to put a therapy consult in. We will help you with that transfer, we will help you problem solve it. We're not gonna come and do the transfer every time for you, but we will help walk you through it, problem solve, figure out the best way to do it the first time if there's something different, something unusual about it. Or if you're just not comfortable with that transfer. It's perfectly okay to start getting us involved with those types of things. We just want everybody to understand we may not be able to come at the drop of a hat. We'll work it in as part of our therapy session, and our ultimate goal is to teach the bedside nursing staff and families how to do that transfer so that they can move on. And then we also ask that you pass that, if we've set up a plan a certain way to do it, we ask that you just pass that on from shift to shift so that everybody's consistent across the board. We can go from there.
Okay. In the ideal world, in that extubated adult, when should we be getting them up and out of the bed?
As soon as they're extubated.
As soon as they're extubated. So even potentially day one if they came back early?
Absolutely.
Okay.
Yep. As soon as they're extubated and awake enough to participate.
Okay.
If they're still completely sedated, you have to question whether or not it's appropriate at that point. But if they're awake, they're able to participate at least some, yes. The sooner we get them moving, just like any surgical procedure, the sooner we can get a person up and get moving, the better pain control that we have, better long-term outcomes from a pulmonary standpoint, from cardiovascular and everything.
So,
just works better.
so to the chair day one and walking,
Walking as soon as possible afterwards.
okay?
So, and participating with their ADLs and everything else, so.
And Chris, you're not this video is specifically addressing adult care, but you would recommend that as well in any of our pediatric
Would recommend that in
patients?
any of our patients.
Yeah.
You know, and if you're looking at an infant, it's getting them sitting up, getting them moving around, going into their normal, you know, what a baby would be doing. Most of our babies, you know, if you have a baby at home, they don't lay there day after day on their back. They're moving, they're sitting up, they're in different devices. So utilizing those as soon as possible with that population.
Okay.
And in terms of self-care, I mean, a patient can participate with the head of the bed elevated so that they're sitting up that way, or if they can sit in the bedside recliner or on their commode chair and participate in a bed bath and starting to get dressed and those kind of things. Have them upright so that they're working on more of their overall strength and endurance than just laying in bed and being fully supported or having nursing complete everything on their own. The other thing I wanted to touch base on real quick is the dysphagia and what to look for in terms of aspiration at the bedside. So typically we would start with ice chips. So you feed the patient 1 or 2 ice chips and see how they do with chewing and swallowing. So are they able to chew appropriately, or do you notice that they're only chewing on one side? You know, those kind of things. But after they swallow, are they initiating a timely swallow? And after that swallow, have the person talk back to you. And listen to their voice. Is it a nice, clear, strong voice that you're hearing, like when they normally talk to you, or are you hearing kind of like a gurgly, sound, or are they coughing? If they're consistently having a gurgly sound or coughing, that's when you need to contact the dysphagia team, because they're most likely not protecting their airway 100%. And so some of that water, ice chips, is going into the airway, which we definitely don't want. After ice chips, you can do liquid from a spoon. So I would start with a spoon versus an open face cup, because you can control the bolus that way. Same thing, after she takes a swallow, have her talk to you. You can have her say hi, make a sentence, or have a conversation, but at least listen to that voice and listen to them and kind of observe your patient too. Are their eyes starting to water? Are they coughing? Do they seem like they're just struggling with it? Those are the signs that you're looking for, that they're having trouble. But if they seem to do okay with that, then you can progress. The one thing to kind of stray away from is straws right away, because straws is the fastest way that you can swallow bolus. So if you, and it's the hardest way to protect your airway. So if you can start with an open face cup or sips from a spoon, I would start there and then slowly progress, especially if they're just coming off sedation medications and they're not fully aroused. You definitely want to start slow versus just handing them a straw and having them chug away. So.
One other quick tip I'll give as far as getting patients up and out of bed, especially as we start doing this sooner and faster. Our bedside chairs are fabulous to a point, but a couple things to remember: they roll. So they're great for positioning, you can get them where you want, but make sure before you ever get a patient up that you make sure that those locks are on in the back and that they're engaged. Give the chair a little push, give it a little shove to make sure it's not going to move. The other thing is that they do rock. So what I like to do when I get a patient into the chair is I like to bring that chair as far forward. You can even have somebody else kind of hold it for you. What I have found by accident is don't put your foot under there to hold it up, because you think you're going to be able to hold it and they weigh more than you do. So you kind of get your foot crushed under there. But you want to stabilize that chair the best you can so that they're coming into a stable surface. Same thing for coming up and out of the chair. So you want to have them shift their weight as far forward into that chair, because that's going to stabilize it. Again, have somebody hold it so that as you stand up, it doesn't spring up. All right? But otherwise, these chairs work well. Just know that this, with the full recline, is absolutely no different than laying in the bed. This is not being up. This is being in a full recline position, because if you look at this actual position, we can achieve that same position in bed. Now, yes, there are benefits to getting to the chair and moving and all of that. So if they get tired, we should not start them here, though. They should start here. If they need those legs up, that's okay, especially for edema control, anything like that. We can keep those legs up, but we don't want that full recline right away. If you need to do a little bit of a recline, you certainly can do that, but we don't want that full recline right away. And when they're in the chair here, you can use pillows, you can use your wedges, your blankets, things like that to kind of put along the sides as needed, just to help position, but, or to bring them forward. For some of our shorter adults, these chairs are deep. A couple pillows in behind will make a world of difference for their comfort level.
Okay. All right, well, thank you, Chris, Tracy, and Colleen. Appreciate it.
No problem, thank you.
Enjoy the video.